Welcome to RWJBarnabas Health's Health Talk show. I am Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group. October is Breast Cancer Awareness Month, and breast cancer is one of the most common cancers affecting women. But there are certain steps women can take to reduce their risk factors and detect breast cancer early, when it's much easier to treat. On today's show, we will learn more about the risk factors for breast cancer, early detection strategies, and the latest technologies that are advancing treatments. We will also gain clarification on some newsworthy questions that relate to breast cancer. We are pleased to welcome Dr. Deborah Lue, breast surgeon and medical director of breast services at RWJUH Somerset's Steeplechase Cancer Center. Dr. Lue is also a member of RWJBarnabas Health Medical Group. Welcome. Welcome to the show. Thank you for coming to the show. Can you please tell us a little bit about your background?
Thank you, Dr. Ashinsky. I'm really honored to be here today to talk to you about breast cancer prevention, diagnosis, and most recent treatment strategies. I am a breast surgeon. I am a graduate of Johns Hopkins University and Robert Wood Johnson Medical School, and have been practicing breast cancer treatment for over 30 years now.
So tell us a little bit about breast cancer, risk factors for breast cancer, so that our audience knows particularly what to be looking at.
Sure. So let's talk about women, predominantly focusing on women. Women should know that there are risk factors that are in their control, and then there's some that are not in their control. For example, the woman's largest risk for getting breast cancer is just being a woman and getting older. If all women lived to be about 150, we'd all have some low-lying level of breast cancer. It's just 100 times more common in women than in men, and more common as women get older. There are other factors for breast cancer that are not in her control, such as the age she starts having her period, the age she stops having her period, and any family history of cancers. Those are not in her control. But importantly, there are things that are in her control. Things such as the age she decides to have her first baby, whether she decides to breastfeed or not, the weight that she chooses to maintain, and the food that she chooses to eat, and how much exercise she chooses to do.
Since family history is a risk factor, are there genetic testing that can be done to better assess that risk?
So that woman should know that if she has a family history of breast or ovarian cancer, prostate cancer, thyroid cancer, or pancreatic cancer, she should talk to her doctor about possibly talking with a genetic counselor. If she's had her own personal history of breast cancer, she should talk with her doctor and make sure that she had genetic testing done, particularly if she had a triple negative breast cancer, or she had cancer on both sides of her breasts, or she had a cancer in the past.
Now, for the audience, what is a triple negative breast cancer?
Yeah, so triple negative breast cancer is an aggressive subtype of cancer. I always say that cancers are like people. They're not all the same. They have their own personalities. Some are kind of laid back and chill, and some are very type A or aggressive. And triple negative breast cancer means that she's missing the markers for estrogen, progesterone, and HER2, which are 3 markers we look for on all breast cancers. And if she's missing those markers, that's a sign that she has an aggressive type breast cancer. And she should have genetic testing done, because the testing will help us guide our treatment protocols, and may change some of her surgical management as well.
And at RWJBarnabas Somerset, we do have genetic center where they can go through a whole genetic course with family history.
Yes, we are very lucky to have certified genetic counselors with Cancer Institute of New Jersey. Those counselors will sit with you, take a 3-generation pedigree, and look at your risk factors for a patient's risk factors for cancer. They will also help guide the gene panel that should be used to test this particular person, and they'll help interpret those results when they come back, as well as help devise personalized screening protocol depending on whether or not any mutations do pop up testing.
Again, very good information for the patient. More important, of course, is the genetic counselor itself to help interpret it with the woman or the woman and her spouse or a partner so that they understand what the future can possibly entail.
Yeah, not only for themselves, but also for their other family members.
Their children also, their
siblings.
Their siblings. So it is very important to think about that.
Yeah.
Are there steps that women can do to reduce their risk factors?
Yeah, those are very important. So I don't think we focus enough on that. And there's a lot of recent research looking at the tumor microenvironment. So why do some people develop cancers and some people don't, even with a similar genetic makeup? A lot of it we're finding out has to do with the tumor microenvironment. And this is where the diet that somebody eats, the exercise, the amount of exercise that they do in a day, and the weight that they choose to maintain, whether or not they smoke or whether or not they drink, it affects the cells, right? So whether or not a cell becomes a cancer can be affected by what's going on. I talk about it as the chaos that's going on around them. And so the things that she can do to help prevent cancer are maintain a normal weight, eat a plant-forward diet, get regular exercise, and we have a little bit of a protocol for that. We call it a FIT protocol, which means frequency, intensity, time, and type of exercise actually matters. We're looking for at least 30 minutes of 5 30-minute sessions of cardio per week and 2 30-minute sessions of strength training at minimum exercise to get some benefit. And what the diet, the exercise, the weight management, controlling the amount of alcohol somebody drinks and not smoking, it really affects total inflammation in the body. And inflammation is the final common pathway in the tumor microenvironment that helps decide whether a tumor, whether a cell becomes a cancer, whether it doesn't, whether some of the drugs and stuff that we have to help fight cancers work or whether they don't work. All of that matters. The environment in which a cell grows or doesn't grow helps. So somebody's weight, for example, when somebody maintains excessive weight, fat cells are very pro-inflammatory. That means they produce hormones that help create the environment that promotes tumor growth and development, and can sometimes get in the way with our immune system's ability to fight off that cancer. So maintaining a normal weight is really important. The foods that we put into our body that can be a plant-forward diet is anti-inflammatory. That means that 70% of everything a woman eats should come from some sort of fruit, vegetable, or grain. No more than 30% of her overall diet should come from an animal source, and preferably a lean animal, like a turkey, a fish, or a chicken. We ask that women stay away from fatty meats or fatty animals like pork, and processed meats like bacon. Those are all very pro-inflammatory, and they create a lot of chaos around the breast cells, which creates an environment for cancer development. And conversely, exercise is actually anti-inflammatory. So that's why muscles, when they're working out, they produce myokines, which actually fight inflammation, and they fight free radicals, which help create an environment that is not tumorigenic or that helps tumors grow. So it's a constant battle. Think of it as the good guys and the bad guys that are constantly fighting. So diet, exercise, not drinking too much alcohol also will affect that environment.
As with any chronic disease.
Yeah.
We want to, again, a vegan diet better than an animal diet. The exercise is very important, both cardiovascular, weight training, and some type of core training also.
Yeah, so the resistance training that we ask, like I said, 2 30-minute sessions of resistance training. So the cardio is good for balance and endurance. The resistance training is good for our muscles and for our bones, okay? So for every year that a woman lives after 50, she loses about 1% of her bone density and her muscle mass. So if she's standing tall like this at 50, by the time she's 90, she looks like that because she's lost about 40% of her muscle mass and her bone density just from the aging process. And while there's nothing that can completely stop that, we can slow it down with resistance training. And that's why it's very, very important to do at least 2 30-minute sessions of resistance training minimum per week for women, particularly after menopause.
Now, menopause symptoms, they're important. And of course, in the past, we used to use hormone replacement therapy. Then it got taken off because of the study that came out saying that there was a possible increased risk of ovarian and breast cancer. And now we're back to giving it intermittently. Can you provide your perspectives on any study about that and share the more recent data about hormone replacement therapy?
So talk about a very, very controversial subject, Dr. Ashinsky. That is a very controversial subject. So yes, as you said, back in about 2002, the Women's Health Initiative results came out, which actually they stopped the study because they said that the benefits of hormone replacement therapy were not worth the risk of an increased risk of breast cancer, heart disease, and stroke. Since that time, there's about 1 to 5% only of women in this country that are on hormone replacement therapy right now, and there's 1 billion women worldwide that are going through menopause, and about 1 million women in the United States alone each year that will go into menopause. So it's important that women know what options they have. So the Women's Health Initiative has gotten a lot of flack since that time because of the methodology. A lot of the women in the study were 65. That was the 63 to 65. That was the average age of the women in the study. So those women were actually not perimenopausal or just menopausal. They were actually well into menopause and already at higher risk for heart disease and stroke, as well as breast cancer. They were also non-diverse, those women, and those women were also on equine-based hormone replacement therapy, of which we now don't use equine-based hormone replacement therapy. We're using more bioidenticals. That being said, there is some very recent data from a large Norwegian study that was published in the British Journal of Cancer last year that looked at over 1 million Norwegian women and showed that there was an increased risk of breast cancer with hormone treatments. Okay, it's a sort of a risk-benefit ratio on everything. If we get in a car and we drive every day, even though we may have a risk of a car accident. If a woman is having very strong vasomotor symptoms, mood swings, that she can't tolerate her menopause, that's not a way to live either, right? So I really think that it's a discussion that she needs to have with her primary care doctor, somebody who knows her risks for cancer, right? So you can balance out that use of hormone treatment, and it doesn't have to be forever, okay? It can be for a short term, so that when she's older, she doesn't need to be on it, but helps her transition through that menopausal state so that she can be healthier and well, right? Because it's all about being well.
Again, I want my women who are going through menopause to be able to make it through life. I don't want them yelling, screaming, and ending up with problems. And if I've got one more thing that I can discuss with them that's a possible treatment, it would be wonderful to be able to do that. And again, we're not talking about a treatment forever. We're talking about a treatment for a period of time. And as long as the woman is vigilant about taking care of herself, watching things out, we can hopefully be able to use it without any really detrimental aspects to her life.
Correct. That's exactly it. It's about balance. It's about understanding your options, and it's about a shared decision-making process. It's not an absolute yes or no.
Which again is the way how medicine has changed tremendously. It used to be, this is what you had to do. Now it's a shared decision-making with the patient and the patient's family to make decisions on whether the person should have the medication, not have the medication, or the treatment. The same thing exists for breast self-exams on a woman. Years ago when I started in practice, we used to teach women how to do breast self-exams. We told them every day to do it, one when they're standing in a shower, one when they're laying flat. Then that went by the wayside, but now there's been some changes with that also.
So yeah, I think women should get to know their breasts. If they choose to examine their breasts, they should do it no more than once a month. Okay, don't make yourself crazy, because your breasts do go through normal changes, particularly for a woman who's menstruating. Her breasts will go through a lot of changes within a month, so no more than 1 month at a time. But a woman should know her breasts much the same way she knows her own face. Every day when she looks in a mirror, she knows where the freckles are, where the lines are, where those moles are. So if something new comes up, she will be the first person to know that that's not That's not been there before. That's new. And that's the way I ask that women get to know their breasts, not be hypervigilant about, I have to find this mass this month or next month. It's more just, is this different? Is this me? Is this not me? Because a lot of times women they know themselves better than anybody else, and they are the first ones to pick up a problem when it happens.
They're much better, though, at self-detection than men are with scrotal health also.
Yeah.
So when we're talking about screening, one of the big questions on screening is the changes in mammogram screening recommendations. What are the current recommendations?
So we follow American Society of Breast Surgeons, NCCN, American College of Radiology guidelines for recommending annual 3D mammograms for the average risk female starting at age 40 and continuing yearly until she has less than 10 years left to live.
So again, what we tell women is that starting at age 40 to start doing the screening mammograms. And a 3D mammogram rather than a regular mammogram, because they'll get better results with it. At the same time, the radiologist may get a call back and say, can we also do an ultrasound on the woman, because she may have dense breasts also. So we do the ultrasound on those that they think have the dense breasts, and usually in the bottom of the form from the mammogram, it'll say whether or not they think it should be done or not. And then continuing it until the woman has probably isn't going to be alive more than 10 years. So we're talking about up in the 80s for most people. The recommendations from American College of Physicians talks about 75 to 80. So that's what we're looking at on those.
Yeah, so I feel like, you shouldn't stop. The same reason you're doing screening mammograms on a woman at 75 or 80 is the same reason you're doing them on a woman at 40. It's to detect early breast cancer where the treatment is minimal or not as involved. And it's even more important in a woman at 75 or 80.
Especially because their risk increases with age.
Correct. The risk increases with age, and they may have some more medical conditions than they had when they were 40. So getting less treatment actually matters a lot more for those women as well. So we have a lot of our over 70 population very active and actually very healthy these days. So I think, again, it's an individualized shared decision-making process between any woman over 70 and her primary care doctor who knows her best.
AI, hot topic at this point. Do you think AI tools will help support the diagnosis and treatment of breast cancer?
Oh, yes, definitely. So AI tools they're kind of flooding breast cancer treatment right now, all aspects of it, from diagnosis. AI is being used, algorithms are being developed with mammography, right, to help detect early cancers more than just the human eye and the computer can previously do. They're being used to help develop treatment protocols. They're being used in patient education. They're being used in drug development, looking for protein markers that we can target drugs on in the future. Not quite ready for prime time yet, because I think all of these models need to be validated in clinical trials in the real world setting so that we know that the protocols and the suggestions that are being spewed out by AI are actually going to help improve outcomes for women in the real world and not just something in theory. Plus, you also need to validate that sort of black box with the AI. AI isn't always transparent with how they go from A to B or A to C, right? And so we need to validate their answers, right, in clinical trials.
Good for the future.
Oh, definitely awesome for the future, and hopefully will help us find a cure in the future
Yes.
as well for cancer.
What are some of the latest advances in breast cancer treatment at the Steeplechase Cancer Center at Robert Wood Johnson University Hospital, Somerset? In particular, can you talk to us about SOZO
Okay.
technology, MegTrace, and MegSeed, and how are they helping patients?
So let's start with SOZO. SOZO is that's the actual brand name of a device that uses bioimpedance spectroscopy to measure lymphedema. Okay, so we're screening patients now before treatment at baseline, from when they first diagnosed. It measures your fluid levels. It uses 256 microcurrents, so you stand on it like a scale, you put your hands on these electrodes, and have you ever seen those scales where you stand on it, it gives you your BMI and your muscle mass? It's a more refined that uses that same technology and a more precise and a more refined way. This is an FDA-approved medical device that can measure fluid status. So what it does is it gives us a baseline measure of your fluid status, and we take it again after each stage of your treatment, after chemo if you get it, after surgery, before and after surgery. So we can start to measure for or look for lymphedema long before it becomes clinically evident. And so we can start intervening with so a woman never has to deal with lymphedema. That is one technology that we've got that not a lot of places, particularly in New Jersey, have right now. The other devices that you talked about, technological advancements, are MagSeed and MagTrace. They both use magnetic signals. MagSeed is a magnetic tracer that we place next to a tumor that helps us localize that tumor so I can have a probe in the operating room to find it and remove it. It can be done and placed weeks to months even ahead of surgery so that it helps the flow and the process so a woman doesn't have to go through so many different appointments prior to her surgery and on the day of her surgery. It helps improve the management of her care on the day of her surgery. So MagTrace is really phenomenal though. It's an iron-based liquid tracer that we inject after a woman's asleep, so she doesn't even feel the injection. It travels to her lymph node and it allows us to mark the lymph node. What's pretty phenomenal about it is that it stays in that lymph node for about 30 days, and then because it's iron-based, the body will metabolize the iron, so it will disappear. And what it allows us to do is to mark that node, and if that woman needs to have that node removed, then we remove it. So we will get the pathology after surgery, and if she doesn't need the node removed, she never has to have that surgery, and the tracer will dissolve or get metabolized. If she needs that surgery, we have 30 days to go back and get that node. So what it does is it allows women to get a surgery if they need it, but not if they don't.
Wow.
Yeah, so it allows us to avoid an unnecessary surgery. They're really quite, again, we're one of a handful of hospitals in the state that are using MagTrace right now.
The hospital also now offers DIEP, flap breast reconstruction surgery. What is it and how does it work?
So DIEP stands for deep inferior epigastric perforator. It's an artery that lives in the abdomen. And it's a type of reconstruction, breast reconstruction, that allows a woman to have her breast reconstructed with her own tissue from her abdomen. Gets moved with those vessels, the DIEP vessels, the deep inferior epigastric vessels. It's microvascular technique with the plastic surgeon. So the plastic surgeon will move the abdominal soft tissue up with those vessels and suture those vessels to other vessels on the chest wall. So it allows a woman to get a very natural, if you will speak, using her own tissue, breast reconstruction, and at the same time she gets a tummy tuck. just unwanted side effect, she gets a tummy tuck because all that tissue gets removed.
Wow. RWJBarnabas Health and Rutgers Cancer Institute just opened up a new breast health center in East Brunswick. Can you tell us more about the services available there?
So again, in an effort to try to treat patients where they live, we're trying to extend our services. So there's a lot of our patients down in the East Brunswick area who have to travel up here to get their care. So we are trying, we have a joint venture with New Jersey Imaging Network. So we're trying to provide the screening, the follow-up, the surveillance, particularly for high-risk patients, patients with new cancers, closer to their home, and where they can get their biopsies there as well, trying to get streamlined service.
RWJUH Somerset, together with the Rutgers Cancer Institute, are New Jersey's only NCI-designated comprehensive cancer center.
Yes.
What does that mean for patients?
That means patients get access to clinical trials that they don't otherwise get access to. There is an incredible amount of resource and funding that gets placed into an NCI-designated cancer center as opposed to another cancer center. And that allows us to extend not only good clinical services, but good research services and research opportunities that otherwise might not be available. We have cutting-edge research because we are affiliated with CINJ, and we are actually very lucky that way. Not only are we geographically close to CINJ, but we have access to those services. So we have access to clinical trials that are not available in other parts of the state, where patients can get access to treatments like cancer vaccines and certain medications and chemotherapy agents that are not available at a non-NCI designated center.
What type of support services are available at the Steeplechase Cancer Center to help patients guide them through their treatment?
So we have very strong nursing and nursing navigation that patients have. We also have a boutique, which is very unique. I think I don't know of any other really in the state.
It's actually quite good because I send a lot of my breast cancer patients to that boutique.
Yep, that's good. We have Lisa Lindenberg, who is a certified mastectomy bra fitter, right? They actually use AI to take pictures of the chest wall so that we can get prostheses made that are actually fitted to a woman's chest wall. So they're much more comfortable. They don't move around as much, and that's very recent technology as well that only is available here in our boutique. Our navigators are available throughout the system actually, but at Rutgers, CINJ, as well as Robert Wood Johnson Somerset, each cancer patient gets their own personalized navigator who helps them through that cancer journey, helps with the doctor appointments, with the scheduling. We'll give them a pre-surgical class that shows you literally everything to expect throughout your treatment, as well as on the day of surgery, where to park your car, what elevator to take, what to expect before and after in terms of wound care, dressing care, drain care if necessary. She helps schedule all appointments with all the doctors. She helps she's just there for the patients whenever they need them, whether there's a financial question, a social question, or they just need to vent. Our nurse navigators are amazing that way. They support all of our cancer patients.
Well, the team approach at the Steeplechase Cancer Center is wonderful. The fact that once I give them that phone number and they get the nurse navigator, it's the best care ever. And everyone who complains about medical care, no one complains about the treatment at Steeplechase Cancer Center. They said it's the most wonderful treatment from start to finish. And there actually isn't a finish because of all the support afterwards.
No, so we're very lucky. The cancer center, that's what cancer centers do best. They consolidate care for a patient, and we have a really great cancer center because it's a nice blend of community personalized care right at home in your backyard with all of the advantages of a tertiary cancer center like CINJ. So our patients get the best of both worlds.
And also, we've been talking about women, but men also can get breast cancer. So it's also important that if I suspect anything, to send men to Steeplechase Cancer Center also.
Oh yeah, our services encompass men. So even though it's less common for men to get breast cancer, they should also be aware that if they have any changes in the shape of their breasts, the way their breasts feel, the size of their breast, anything with their nipples, or if they feel a mass, they should definitely contact their primary care and get in to see us as quickly as possible.
As we conclude today's show, what key message do you want to leave for the audience?
I want women to know that breast cancer is common but curable. Okay, the majority of the time in 2025, breast cancer is curable. Get your mammograms, because mammograms are still the only reliable way of detecting breast cancer before someone can feel it. And really be good to yourself and know that the choices you make on a daily basis, the foods you eat, the exercise you do, the weight you choose to maintain, how much alcohol you choose to drink, and whether you choose to smoke, those are phenomenally important factors, and you have control over whether a tumor develops or not.
Thank you very much. Thank you for your knowledge. Thank you for your treatment. Thank you for everything you do for our community, our patients. Thank you for being part of the NCI Comprehensive Cancer Center that's part of RWJBH.
Thank you, Dr. Ashinsky, for having me.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for the medical advice from your own physician. If you need a physician, please call 844-CANCER-NJ, CANCERNJ. For more information about RWJBarnabas Health's cancer services, visit us at www.rwjbh.org/beatcancer.